Good evening, respected professor. My dear students, I welcome you all to our RAISA online academic activities on Webex platform. Today, Professor will be discussing some important 8 theory questions. Without wasting much of the time, I hand over the session to Professor and students. First, I invite Dr. Muthupriya to present the answer for the question. Describe the anatomy of orbit. How is sub-Tenon block done? Dr. Muthupriya, please.
So before we start the session, we'd like to place our heartfelt condolences for the demise of Professor Vasanthi, who was involved in this teaching program for a very, very long number of years with us. Unfortunately, she passed away last Saturday on a Women's Day, World Women's Day. She passed away. We all pray for her soul to rest in peace. And before Muthupriya starts the first answer for the first question, the idea of giving these theory questions, because next is your theory exams, this batch is going to appear for theory. So what I would suggest is, even though questions are given and you share it among your friends, and each one of you are preparing 1 or 2 questions, it is better that all of you plan or in your own way, try to first read about the answers from the book, and then individually you keep a stopwatch and try to answer them within the stipulated time. Because in the theory exam, you are going to get 10 questions in each paper for 3 hours, which means you have 180 minutes to answer the 10 questions, which literally gives you only 18 minutes for each question. So it requires a lot of practice to think fast and write all the points without missing, and also read the questions properly and understand the questions first, and then practice writing them without consulting the books verbatim. So by that method, I think we will be able to gain practice as to how to write the questions without leaving any questions in the examination within the 3 hours time. So because you are giving 2 questions to somebody else and you are preparing only 1 question, don't stop with that alone. Try to prepare the answer for all the questions individually and try to practice them in the notebook. Try to write them with a stopwatch and try to finish it within the time. To start with, today I have given only 8 questions to see how we are able to complete these questions within the hours time available. But if you are able to finish it fast, then we can have the regular 10 questions in each class, and that will give you a good practice to write all the answers within the stipulated time. So with this small hint on your practice or method of learning how to answer the questions in theory, now Muthupriya, you can start presenting your answer for anatomy of the orbit and sub-Tenon block. Sub-Tenon block is not a very popular block done by many of our ophthalmologists. Majority of them do it as a topical or by peribulbar block, and sub-Tenon block is more common in the Western world. And another point I would like to say in this class is, even though we are saying that it is a theory discussion, you will be presenting the answers as you have prepared for your theory answers, and wherever required, I will be supplementing further points which will be useful for you in the practical exams also. Some questions that may be asked regarding that particular topic in the practical exams also. So there I may digress a little bit to the extra points. Otherwise, my PPTs also will have some clue or guidance for you to how to answer the theory questions. Okay? So with this introduction, we'll now go on to presentation by Dr. Muthupriya.
Yes, sir.
You
Good
can go
afternoon.
ahead.
Yes, sir. Good afternoon, everyone. Today my question is anatomy of orbit and how Tenon block is done. Anatomy of orbit. Orbits are symmetrically paired structure separated by the nasal cavity and paranasal sinus by the bones. The orbit is an irregular force-shaped pyramid, and its apex is pointing posteromedially and base is facing anteriorly. The orbital roof is formed by lesser wing of sphenoid bone, frontal bone, and the lateral wall of orbit is formed by greater wing of sphenoid bone and zygomatic bone. The medial orbital wall is formed by lacrimal bone, ethmoid bone, maxillary bone, and lesser wing of sphenoid bone. Orbital floor by the maxillary bone and palatine bone, zygomatic bone. So the walls of the orbit acts as a physical barrier from blunt trauma and anchors the muscles and the ligaments. It acts as a window for the neurovascular bundle to travel along. It contains orbital fat, which acts as a cushion and facilitates the movement of the eyeball, and it surrounds the extraocular muscles and globe. Orbital fat is increased in Graves' disease, which is resulting in proptosis. The blood supply of the eye, it's supplied by the ophthalmic artery, which is a branch of the internal carotid artery, infraorbital artery, which is a branch of maxillary artery, venous superior ophthalmic vein and inferior ophthalmic vein. They drain into the cavernous sinus. They travel through the superior orbital fissure and enters the orbit. Lymphatic vessels, the orbital lymphatic system drains into the preauricular lymph nodes. So orbit, as it said, the apex is formed posteriorly medially by the annulus of Zinn. It is a fibrous ring surrounding the superior, arising from the superior orbital fissure. The base is formed by the surface of the cornea, conjunctiva, and the lids. The globe movements are controlled by the rectus muscle, that is the superior rectus, inferior rectus, medial and lateral rectus, and the oblique muscles like superior oblique and inferior oblique. The actions of these muscles are superior rectus, it elevates, adducts, and rotates medially. Medial rectus, it only adducts. Inferior rectus, it depresses, adducts, and rotates laterally. These are the three muscles which adducts, and abduction is done by lateral rectus, superior oblique, which depresses and abducts and rotates medially. Inferior oblique, which elevates, abducts, and rotates laterally. Optic canal is located medial to the superior orbital fissure, which transmits the ophthalmic artery and optic nerve. Injury to this can result in hemorrhage and optic nerve injury resulting in blindness. The rectal muscles arises from the annulus of Zinn near the apex of the orbit and is inserted anterior to the equator of the globe, thus forming an incomplete cone. Within the annulus and the Zinn, annulus of the Zinn and muscle cone lie the optic nerve, oculomotor, abduction, nasociliary, ciliary ganglion, and blood vessels. These nerves originate from the cranial fossa and enter into the orbit via the superior orbital fissure. Nerve supply, the superior branch of the ophthalmic nerve supplies the superior rectus and levator palpebral muscle. The levator palpebral muscle elevates the upper eyelid. Hence, third nerve palsy result in down and out eye and ptosis. Inferior branch of ophthalmic result in supplies the medial rectus, inferior rectus, and inferior oblique. Abducens nerve supplies the radial rectus, and trochlear nerve, it runs outside and above the annulus and supply the superior oblique muscle. Sensation of the cornea, perilimbal conjunctiva, and supranasal quadrant of nerve eye is supplied by the nasociliary nerve. The remaining of the conjunctiva is supplied by the lacrimal, frontal, and infraorbital nerve. Coming to the Tenon's capsule. Tenon's capsule is a thin membrane that envelopes the globe from the orbital fat. The inner surface is smooth and shiny and is separated from the outer surface of sclera by a potential space called subtenon space, which contains delicate bands of connective tissue. Anteriorly, the facial sheath is firmly attached to the sclera, 5 mm lateral to the sclerocorneal junction, and posteriorly, the sheath fuses with the meninges and around the exit around the optic nerve. Injection of local anesthetic under the subtenon's capsule may block the sensation from the eye by the action on the short ciliary nerves, and akinesia can be achieved by the action on the motor nerve fibers. Vision may be affected by the direct action on the optic nerve as anesthetic solution diffuses along it. Coming to the subtenon's block, before giving Tenon block, peri-op routine investigation can be done, and specific inquiry regarding the bleeding disorders and related drugs like anticoagulant intake should be asked due to the increased risk of subconjunctival hemorrhage. INR should be less than 3.5 to proceed with the surgery. All monitoring and equipment should be fully functional. Baseline investigations should be like heart rate, BP, SpO2, ECG lead should be connected, and baseline readings should be recorded. This technique involves obtaining surface anesthesia, installation of the antiseptic solution, and surgical access to the subtenon space by the insertion of blend cannula and subsequent administration of local anesthetics in the subtenon space. Surface anesthesia is obtained by topical local anesthetics like tetracaine, amniocaine, benzocaine, and or cotton bud soaked with topical local anesthetics. Antiseptic solution like 5% povidone iodide can be given to provide antisepsis. And surgical access to the subtenon space, it can be assessed from all the 4 quadrants, but infranasal is the most commonly assessed because of the placement of cannula can allow good fluid distribution superiorly and avoid the area of access from surgery. The patient is asked to look upwards and outwards, and under sterile condition, the conjunctiva and the Tenon's capsules are gripped with the non-tooth forceps of 5 to 10 mm away from the limbus. A small incision is made, and these layers are cut with a scissor and a blend cannula is inserted. A 19-gauge blend cannula, which is usually metallic, 2.54 centimeter long, with the blunt end is inserted. Local anesthetic solution like about 2% lignocaine without adrenaline can be given. Usually a volume of about 3.5 to 3 to 5 ml is given, generally given. Intraoperatively, the patient should be like adequately. The patient must be verbal and tactile contact should be maintained throughout the procedure so that the patient won't be anxious. And delivery of oxygen under the drape may provide an oxygen-rich environment for the patient to prevent hypoxia and rebreathing. The subtenon block is usually primarily advocated for cataract surgery, but is also affected in vitreoretinal surgery, panretinal photocoagulation, trabeculectomy, strabismus surgery, and delivery of drugs. Limitations of the subtenon block, like subconjunctival hemorrhage and ecchymosis are usually common. It is difficult to perform in patients who have a previous subtenon block in the same quadrant, previous retinal detachment, large pterygium, strabismus surgery, or eye trauma or orbital infection. The complication arising from subtenon block may be limited to orbit and can manifest systemically. Complications like due to topical local anesthetic may produce stinging or burning sensation on application, and introduction of cannula into the potential space may have a feeling of pressure during injection due to widening and stretching of potential space. This can be reduced by gentle insertion of the cannula or a slow injection of warm local anesthetic agent. Ecchymosis, which is the swelling of the conjunctiva, occurs due to anterior spread of local anesthetic agent after injection. It can be avoided by proper dissection and avoiding a large volume of local anesthetic. Simple measure like gentle pressure on the globe can reduce the swelling. Conjunctival hemorrhage, red eye following subtenon block is common occurrence. It can be due to the dissection, which may result in damage to the vessels, or by handling of the conjunctiva. It can be reduced by having a topical vasoconstrictor like epinephrine added to it to reduce its incidence. Sometimes akinesia or eyelid movements can be occur due to reduced blockage. Some surgeons prefer some akinesia is not preferred in modern surgeries, but inadequate operating conditions are not preferable for the surgeons. Major complications are life and sight-threatening complication. Sight-threatening complication such as globe perforation, retinal or choroidal vascular occlusion, optic nerve damage can occur. Life-threatening, serious life-threatening complication such as central nervous system spread of local anesthetics can cause death, but it occurs in rare cases. Rarely, intravascular injection can occur. It can be avoided by careful aspiration and slowly injecting the local anesthetic drug in a fraction amount. Verbal contact should be maintained throughout the procedure. Some of the adjuvants used along with the topical local anesthetics are epinephrine, hyaluronidase. Sedation is commonly avoided due to the increased risk of intraoperative events. So, subtenon block is a simple and effective procedure, relatively safe procedure, performed in cataract surgery, absolutely safe, sir. Thank you, sir.
Very good. It was a very exhaustive presentation. As I said, I don't know whether you will be able to complete this answer within the 18 minutes time if this question is asked in your examination. So it can be made a little more concise.
Okay, sir.
And the subtenon block can be administered only after putting or application of the speculum to open the eye. That's a very important point that has to be mentioned, because your peribulbar or retrobulbar block, that they all can be administered from the outside through the skin. So even if the patient keeps the eye closed, nothing will happen. Whereas subtenon block definitely requires the application of the self-retaining speculum to be applied to the eyelids to keep the eyeball exposed. And that is the reason why we have to first instill local anesthetic to remove the sensation from the conjunctiva. So the commonly used drug by most of the ophthalmologists for this purpose is paracaine, which is commercially called paracaine, which is paracaine. And the other amitocaine and lidocaine are all not commonly used. And the cleaning of the eye with povidone iodine should be done only after the sensation is abolished by application of the local anesthetic. So if you happen to work with the ophthalmologist, you will know that they will advise the patient to apply the local anesthetic drop. They come from home itself. So 2 to 3 times applications will nicely anesthetize the entire conjunctival area. The patient won't resist the application of the self-retaining speculum also, and the further application and cleaning with povidone iodine will not cause any irritation. Okay? So if first cleaning is done as is done in other parts of surgery, it will cause a severe burning to the eye. So patient will have the difficult time if straight away povidone iodine is applied to the conjunctiva. And if you can remember the names of the instruments that are being used, one is called the Mossfield forceps, which you said non-tooth forceps to hold the conjunctiva to make the incision.
Yes, sir.
That instrument is called the Mossfield, M-O-R-F-I-E-L-D-S, Mossfield's forceps. And the scissor that is used is a crisscross scissor which has the name of Westacott. W-E-S-T-A-C-O-T, Westacott scissors. These two are the instruments that are used normally. And compared to the peribulbar block or retrobulbar block, which has to be given either through the skin or the conjunctiva, patient will not feel that they have been given anesthesia, because needle phobic patients will be there. So when you try to go and give an injection in the eye in a conscious patient, many may get scared and they may say, are you going to give me injection in the eye? So for such needle phobic patients, this technique is very, very useful, because first you anesthetize the conjunctiva with a local anesthetic drop, then you put the speculum, then in the anesthetized eye you are going to hold the conjunctiva, make a opening, introduce the blunt cannula, all those things. So patient will not feel anything. So patient will be very happy that now injection has been given, and the volume also is not more than 2 ml is sufficient. Okay, 1.5 to 2 ml will be enough to spread over around the globe and produce a very good analgesia. So 3 ml is too much of a large volume. 3 to 5 ml is enough even for a retrobulbar or peribulbar block. Whereas for the subtenon block, we may not exceed maximum 2 ml. That will be quite more than sufficient. And only when you give 3 or 5 ml, patient will feel the pressure sensation because of the large volume, which is there is not enough space for the drug to get retained there. So that is the reason patient may feel the pressure sensation. Okay. So, and these are the, and you have nicely included this applied anatomy also. So some of the cases of ptosis may be coming for surgery, congenital ptosis or acquired ptosis. It may require repair of the levator palpebrae superioris, which may be paralyzed or cicatrized. So such patients also may come for correction of the surgery with a fasciolata sling. They usually take a small bit of fasciolata fibers and make a sling and attach it to the frontalis muscle so that the patient can use the frontalis to open the upper eyelid and have a good vision. Okay. So I will just share my